everyone, and welcome to the webinar entitled Syringe Service Programs, State and Local Perspectives on the Role of Policy, Funding, and Partnerships, hosted by the Office of the Assistant Secretary for Health. My name is Julie Cahoon, and I am from Kaufman and Associates, assisting with today's webinar. Before the presentation begins, I'd like to highlight the main features of your webinar interface. You should all see the first slide of the PowerPoint presentation in the middle of the screen, and to the bottom right of your screen is closed captioning. Just above closed captioning is the Q&A pod. Please enter a question for our presenters at any time in the Q&A pod. Questions will be addressed at the end of the presentation. If you need technical assistance during the webinar, please type the issue into the Q&A pod, and one of our tech support staff will respond to you directly. Finally, please be aware that all phone lines have been muted, and this presentation is being recorded. I will now turn it over to Sharon Hicks with the Office of the Assistant Secretary for Health. Sharon?
Thank you, Julie, and welcome to all of you. It is my pleasure to greet you on behalf of the U.S. Department of Health and Human Services and the Office of the Assistant Secretary for Health. We are excited that so many of you have joined us today. My name is Sharon Hicks, and I am one of 10 regional health administrators across the nation who work to catalyze public health action on important issues through our regional expertise and networks. Today, we are pleased to be partnering with our Office of Infectious Disease and HIV/AIDS Policy to present Syringe Service Programs, State and Local Perspectives on the Role of Policy, Funding, and Partnerships. This is the second in a three-part series, and today we are traveling to Kentucky, North Carolina, and New Mexico to hear about their efforts to build and expand syringe services programs. We will explore questions like how do you gain support and community buy-in? How do you craft policy and bring it to practice? And how do you leverage the power of data and partnerships? Our speakers include Dr. Connie Gail White, Deputy Commissioner for Clinical Services, Kentucky Department for Public Health, Mr. Danny Staley, former Director of the North Carolina Division of Public Health and currently serving as Chief of Caribbean Operations at the Association of State and Territorial Health Officials, and Mr. Andrew Gans and Joshua Swatek, managers focused on harm reduction and HIV at the New Mexico Department of Health. Unfortunately, our Assistant Secretary for Health, Admiral Brett Giroir, is not able to join us this afternoon, but you can hear his enthusiasm and perspective on this topic by listening to a recording of our July 30th webinar at hiv.gov. Just click on Federal Response, then Policies and Issues, and then Syringe Service Programs. The opinions, findings, and conclusions expressed by speakers during this webinar are strictly their own and do not necessarily represent the opinion, views, or policies of the Office of the Assistant Secretary for Health and the Department of Health and Human Services. Nor does mention of trade names, commercial practices, or organizations imply endorsement. References to publications, news sources, and non-federal websites are provided solely for informational purposes and do not imply endorsement by OASH or HHS. OASH and HHS assume no responsibility for the factual accuracy of the content of the individual organizations found at non-federal links. Now for logistics. You are currently in listen-only mode. If you have any questions during the presentation, please type them into the Q&A pod in your control panel. We have devoted time at the end of the webinar to answer some of those questions, and we will respond to as many as possible. Also, at the close of the webinar, there will be a pop-up screen with 6 questions for you to complete. This is your opportunity to share your thoughts about this and future webinars. We will also send you an email with a recording of the webinar, a link to the presentation slides, and the contact information for your regional health administrator. The topic of this webinar is extremely timely. Just this month, we saw 2 major news stories that document the increase in HIV cases among individuals with opioid use disorder. The Boston Herald reported that the number of new cases of HIV among people with substance use disorders is skyrocketing in Massachusetts. And Politico reported the primary cause of a cluster of HIV cases in a rural county of West Virginia was from people who used drugs sharing contaminated needles. And now we're going to switch to another slide set. Our department recognizes that syringe service programs are a key component in reducing the transmission of infectious disease and saving lives. And although Admiral Giroir is unable to join us, he is extremely enthusiastic about including SSPs in our strategy to end the HIV epidemic. And I am pleased to present a few slides on his behalf. The opioid epidemic is the most critical public health crisis of our time. In 2017, we had more than 70,000 drug overdose deaths, and 48,000 of those were caused by opioids. These deaths include those related to prescription opioids, heroin, and synthetic opioids, such as fentanyl. And every life we lose to this epidemic is one too many. In addition to overdoses, there are also profound infectious consequences among people with opioid use disorder who inject drugs. This includes transmission of HIV and viral hepatitis, both of which have significant lifelong impacts. There is also the risk for bacterial infections such as endocarditis, which affects your heart, as well as skin, bone, and joint infections. These infections are often very difficult to treat and require surgical intervention and weeks or months of antibiotics in order to cure the infection. In order to end the HIV epidemic, we must understand the populations and geographic areas that are hardest hit. There were more than 38,000 new HIV infections in 2017, and more than half of those, 52%, were in the South. 66% were among gay and bisexual individuals, and 9% were among people who inject drugs. And we know we can prevent many of these new cases by increasing access to comprehensive SSPs. People who participate in SSPs are 5 times more likely to enter drug treatment and 3.5 times more likely to stop injecting compared to those who don't. Today's webinar is part of an effort led by the Office of the Assistant Secretary for Health to collaborate with federal, state, and county stakeholders to create and expand syringe service programs in vulnerable communities across the nation. This is a map of the 10 HHS regions that are currently engaged in this work. And I am thrilled that our first 2 speakers represent my region, HHS Region 4. And our last 2 regions represent HHS Region 6. Both regions are disproportionately impacted by HIV and in desperate need of innovative strategies. Our first presenter is Dr. Connie Gail White, Deputy Commissioner for Clinical Services, Kentucky Department for Public Health. Dr. White will share more about Kentucky's experience. Dr. White?
Hi, thank you, Sharon. It's certainly an honor for me to share the Kentucky experience and highlight the hard work done by our local health departments to fulfill the 2015 legislation, allowing us to offer this life-saving service of syringe service programs in Kentucky. Okay. This slide mimics something that Sharon has already shown you, and it reflects the death rate of drug overdose deaths in Kentucky. 15% decrease in deaths in 2018 would have equated to around 230 people who survived the year and did not die of a drug overdose, but clearly our work is not done. This map shows the state of Kentucky and the number of deaths by a county. The darker colored counties, the darkest colored is Jefferson County, where the largest city in Kentucky is, Louisville. The other 2 darker counties are Lexington, and then at the very top of the state is our northern Kentucky counties that is immediately across the Ohio River from Cincinnati. And the gray line you see there separates the Appalachian from the non-Appalachian counties. This gives an impression, if you look at this map, that the drug overdose crisis is an urban crisis in Kentucky. However, if you look at this slide, this is a representation of using an opioid overdose risk index that we proposed when we wrote our SAMHSA proposal for the original STR funding. And you can see if you incorporate other factors such as overdose ED visits and hospitalizations, if you look at neonatal abstinence syndrome, you look at the average MME or morphine milligram equivalents per county, the burden of the opioid epidemic is definitely a rural burden, and it has very heavily affected our Appalachian region. Now, this map has a lot of information packed into it, so I want to break it apart, part by piece. In the upper left-hand corner, you see a U.S. map that shows the counties who have been determined to have an increased vulnerability for HIV and hepatitis C infections among people who inject drugs, or as I call them, the green counties. Of the 250 counties in the U.S. that met that qualification, 54 of those were in Kentucky. Now, on the map, the red stars show where there is currently an active syringe service program that has opened since March 2015 when legislation was passed and signed into law. The open red stars mean that the program has been approved but has not yet become operational. Kentucky currently has 63 operating syringe service programs in 56 counties, and we have 3 counties that have approval, but they have not become operational yet. The list that you see on the right side of the slide shows the 54 counties with those in red being the ones that have current operating SSPs. I want to take you through the history of the crisis in Kentucky and explain why we feel that these counties in eastern Kentucky were ready and even eager to take this bold step fighting the overdose crisis. Go all the way back to 2001. The DEA developed a map by zip code of the highest opioid prescribing counties in the U.S. One of those was in Northern California, one in Southern California. The remaining 7 were in Eastern Kentucky and West Virginia, 2001. In 2003, our representative, Hal Rogers, which includes many of the counties in eastern Kentucky that you see on that map, saw an article in the Lexington Herald Leader newspaper that exposed the opioid epidemic in eastern Kentucky in 2003. That prompted him to develop the organization Operation Unite. Unite stands for Unlawful Narcotics Investigation, Treatment, and Education. Operation Unite in 2004 opened a hotline or a helpline, and on that line, 1 out of 10 people that called in reported using IV drugs at that time. In 2010, Representative Rogers and Representative Mary Bono Mack developed the Congressional Caucus on Prescription Drug Abuse. A full 9 years ago, Congress did recognize that this was a battle that needed to be fought. And in 2018, our Operation Unite helpline reported that of the calls that they received, 10 out of 10 of their callers were using their drugs IV. The game has changed in Kentucky now. So let's go through the legislative approval process. Our Office of Drug Control Policy and the Justice and Public Safety Cabinet, along with the chair of the Kentucky Senate Judiciary Committee, determined that a host of legislative initiatives must be introduced to turn the tide on this epidemic, but it failed to get out of committee. Next slide. My screen has been blocked. There you go. Thank you. In 2015, after a lot of homework done by the Legislative Research Commission, a 14-chapter bill that was dubbed the heroin bill by the press was introduced. We call it in public health, we call that the harm reduction bill, as it included legislation on pill mills. It provided for a Good Samaritan provision. It loosened prescribing restrictions that we had on the naloxone in Kentucky. It did legalize syringe service programs and also included a multitude of other important criminal justice reforms. With Austin, Indiana, only 30 miles from our border, just across the river from the city of Louisville, along with our already skyrocketing Kentucky hepatitis C rate, there was a sense of urgency in our General Assembly that something must be done. We were able to emphasize that decreasing the risk for first responders from needle sticks with a local SSP, along with decreasing those loose needles that you see around in your community. And I've pretty much agreement by everyone that treating the disease of substance use disorder in the criminal justice system had not been effective. All of these was the perfect storm to get this pill passed. It was initially expected that only about 3 counties, the previously mentioned counties with the largest populations, would be the only places that we would adopt SSPs. But with our time, by this time 15 years, of drugs killing and disabling our families and friends, people were ready to do something. Van Ingram, our executive director of the Office of Drug Control Policy that worked this bill through at the Capitol, said that when he opened his email the morning after the bill passed, the first one he saw was from a pastor. Van was a little worried that maybe he had started receiving hate mail already. On the contrary, the pastor had read about the bill, and he wanted to know what his congregation could do to help. So the method for developing or creating a syringe service program in Kentucky has 3 parts of approval. First, the local board of health in the county must approve development of the SSP in their local health department. This is quite a lift considering the fiscal restraints that our local boards of health have been feeling at this time. After the Board of Health approves, then you have to go to your city council, and the local health department must not only get the city council members' approval, but they also must get approval of the magistrates in the county government. Now, this is a very complex problem, as you can imagine, because you also had to get buy-in from city police and the county sheriff's office. Many of our local health department directors and their staff were busy holding open forum meetings in the community for community input, visiting Rotary clubs, speaking to faith-based community members, and also presenting to the local bank board of directors. What we're now beginning to see that after several years of acceptance by these 3 layers of governance, elections have happened, and the face of these bodies are changing. It's a very important and crucial job to continue to introduce these people to the local data of their crisis and to introduce them to the principles of harm reduction. So if the bill was specific to local control, we at the state level decided our best first move would be to develop a document that could be used as a guide for the health departments and maybe used as a template as they develop their program. So we developed a document like this using assistance from national harm reduction organizations. This is about harm reduction, and it's not about needles and syringes only. The 8 principles of harm reduction tell us that we must accept that there is a drug use, and we can't ignore or condemn the clients that do this. We have to understand that the drug phenomenon is very complex, ranging everywhere from severe abuse to total abstinence, and recognize that some methods of use are safer than others. We have to establish criteria for successful interventions and policies to give people good qualities of life. We have to deliver non-judgmental and non-coercive or methods to try to help them reduce their harm. We have to empower them to make good decisions and so that they can prevent their own harm, and then they can share this information with others. I skipped the provide, which is creating programs and policies to give these folks a voice. I appreciate the harm reduction community's mantra, nothing about us without us. We also have to acknowledge the social determinants of health because poverty and class, racism, social isolation, past trauma, sex-based discrimination affect vulnerability to and the capacity to be effective for a client to deal with these different types of drug-related harm. And finally, we have to recognize that there are realities and danger in drug use and not to minimize or ignore these dangers, both in illicit and illicit drug use. So what do these SSPs programs have in Kentucky, and what services do they provide? Well, some do more than others. Some are open only one afternoon a week. And some of them have figured out a way to incorporate this into their daily workflow. We already have one of the highest rates of hepatitis C in the country, so testing for hepatitis C and HIV are critical, especially as we've seen the pattern of drug use change to more and more IV use. as we continue to battle against one of the largest hepatitis A outbreaks in the country that targeted those that use illicit drugs and the homeless, Kentucky SSPs were one of our important venues to be used to vaccinate. We have a large push to provide our clients with free naloxone, and we're doing so through our SSPs. Many LHDs have hired peer support specialists to be available during their SSP hours, while some local treatment facilities allow them to be present while the program is operational. The importance of assisting clients to receive treatment for their infectious diseases, from infected infection sites to those ill with potential sepsis leading to, as Sharon said, endocarditis, brain abscesses, soft tissue infections, bone infection, as well as continuing treatment for HIV, Hep C, TB, and other medical needs are vital. And finally, if a client is ready, using our real-time treatment locator called KentuckyHelpNow.org, clients can have the opportunity to be connected with substance use disorder treatment. So SSPs in Kentucky, how do we sustain them? Well, first we have to go through the local approval process, which is three-tiered, as I told you, and is somewhat complex. Funding is always an issue, and our LHDs have become very creative finding local funding. We here in Frankfurt at the Capitol have worked to provide available EIS funding from the HIV program that allows for education and testing. Our sister agency in the Department for Behavioral Health, Developmental, and Intellectual Disabilities, who were the recipients of SAMHSA's STR and SOR funding, have been generous working with our SSPs. Our Department for Public Health has also used some of our public health preventive block grant to fund communities to educate, answer questions, and develop community buy-in for SSPs. Grant funding to our universities has also been an excellent opportunity for assisting our syringe service programs. And in true public health fashion, one of our local health departments have no personnel costs associated with their SSP, because they have 2 retired public health nurses that come in every Friday afternoon and voluntarily staff their program. It's that important to them. Our first effort at data collection was cumbersome, and we have just revamped that system within the last 3 weeks. You need to decide a data system that makes you aware of what data you're going to need. Legislators will want different information than the CDC will want, which is very different than what the press might ask for. Redefine and revamp your data collection system accordingly. And informing the public and your local legislators of the critical importance of what you do. Regular local data reports will help them to keep the importance of this program in the eye of local government. Kentucky is new to this process. The bill was just signed by the governor in March of 2015, and the first SSP opened in Louisville in June of 2015. Some of our 63 SSPs are less than 6 months old. Some of our bordering counties without SSPs have law enforcement personnel that don't honor the product provided by the neighboring SSP. But we are learning, and our citizens' lives depend on this program. We look forward to hearing from the other presenters at this webinar, and again want to thank OASH for inviting us to participate. Thank you, Sharon.
Thank you so much, Dr. White. And I have personally visited syringe service programs in Kentucky, and I was absolutely amazed with the care and the concern that was poured on every single person that walked through that door. So your work is really inspiring. Our next presenter is Mr. Danny Staley, Chief of Caribbean Operations at the Association of State and Territorial Health Officials. Mr. Staley is the former director of the North Carolina Division of Public Health. Mr. Staley?
Thank you, Sharon, and a pleasure to be with you today. I want to start by saying kudos to Dr. White, and she's a perfect setup, and I think that we shared many of the same experiences about the growth of trying to put together an SSP program. In public health, we all know we're no strangers to sensitive topics, and probably one of the most sensitive that we have dealt with is the establishment of SSPs. I go back to the fact that in North Carolina, I had this great privilege of working through a great team with outstanding community partners, and I do appreciate the whole notion of nothing for us without us, and that those principles of harm reduction ring true in our state as well. So I really wanted to focus a little bit because I think the other presentations do a great job of highlighting the sort of great things and mechanics about SSPs. But in North Carolina, you know, it was a challenging environment, and working in that challenging environment, I wanted to demonstrate we can make progress. We can make a lot of progress toward our goal of helping through a multitude of pandemics that were occurring. And doing so, I really wanted to talk about the regulatory and policy structures that were there, and those making those changes, working with data, and creating, I would say, impactful work and sustainable work. Oops, go back one. Fingers too fast. The impact of a safer syringe program, or the syringe service program, is tremendous. And in the past, I go back to my early career in public health in the 80s and 90s. It was basically a conversation stopper to start talking about doing a syringe exchange or needle exchange at the time was what we were using. And I would just say North Carolina was in the midst of dealing with the opioid epidemic response. And the conversation came up about injected drugs as people began to transition from the prescribed medications to street medications, which were more accessible and cheaper as many of the controls have been put into place. And what happened was a lot of collateral disease began to happen. And then we began to have a conversation opener. People were really beginning to want to have the conversation around syringe services programs. And it was really nice, the fact that we had partners who would come to us and talk to us about some of their concerns, some of the needs they had. One of the big players in this arena was law enforcement. And I'll talk a little bit more about their role and how critical they were as a partner for us. And through that, we were able to have the conversations that began to align political will, science, and community. And if you've ever been in that little sweet spot where those things start to align up, you know big things are about to happen. And it's great. The fact was North Carolina had a lot of barriers in its written regulations and laws, as well as community and perception barriers that we began to break down. And it took a lot of help from a multitude of partners to really get in there and tell their 5-second story, if you will. And it was not something that we saw, as you'll see in the next slide, that we could do with one fell sweeping piece of legislation. It actually took us a couple of tries to get it where we needed it. Might not be perfect, but it was progress. And then really, I would say one of the biggest keys for states and communities is finding the right people to carry your message and helping them craft rich messages that really get around the need, the point, and why we as a community need to address this. I think Connie alluded to the fact that politics are local. And when you're working in a state office, it really does require a lot of community engagement to help change those local politics. One of the things that we bumped into as we were going along the way with around policy change was the I don't want this in my backyard, and I don't ever underestimate the sway of one negative vote or one negative comment in the community when they're really heightened and sensitive about a topic. And so there was a lot of education and a lot of working through people, with people. Not something that always the health officer could do, but usually what pastors and others could do to help bring about community change and perception. So I mentioned briefly the timeline a second ago, and really wanted to say that evolution of our policy began because of the fact that we had law enforcement coming to us with accidental needle sticks. Not a lot, but a few. And we had been engaging the law enforcement community on a number of other issues. And they basically said, well, I would do anything to protect my officers. And they began to have the conversation with us about, well, if I disclose that I have a needle or a syringe in my pocket, then are you going to charge me with drug paraphernalia? And that led us up to some early legislation with a pilot, which allowed us to not to exclude from prosecution provided self-disclosure. That gained some strength because, as with most of our policy change and efforts with pilots, you have to report back, which always gives you an opportunity to continue your song, if you will. And that allowed us to get our foot back in the door and have the conversation with the legislators and tell them exactly, well, we have this community. But it also helped us to build better relationships with other communities who had heard about the pilot, and they were wanting to have authorization. So they wanted to go down the road of not having needle possession as a criminal act. So they were one of our big, strong voices going back to the legislature. In 2016, we went back and had a statute, a change in statute, which allowed for needle exchange programs or syringe service programs. And then we built upon that again in 2017, which allowed us to utilize non-state funding that allowed local governments to get creative on ways they could fund these services in their communities. Speaking about bringing our partners together, we found that when we started talking, we had providers, we had behavioral health, we had the harm reduction community, we had the recovery community, we had nonprofits, we had pharmacists, all of which wanted to do something in this space. And we all had this common mission about wanting to help community members and wanting to reduce the harm and reduce the collateral diseases that we were experiencing. In really trying to bring pieces and parts together, we wanted to have complete messages out there, and we sort of used this topic called moral foundation theory. It's fascinating work. You have time to research it. But what we felt we would do was go beyond just talking about it's the right thing to do, or going beyond the fact that we're wanting to protect people. What we wanted to do was to utilize the public health data that we had and to start hitting upon all the aspects of everything from the cost of the collateral disease, the cost associated with treatment, cost to our community in real dollars, and help to bring about a rich message which did more than just say it's the right thing to do. As we looked at reporting requirements, that we felt like that was going to be the key to giving us data. Looking at what is it when you set up a syringe services program do you need to demonstrate and show the value so that when you're going back the next year or the next year for changes, or to talk to the people that say not in my backyard, and you want to say, hey, I've got a safety component. The police are aware of this. They are engaged in our work. They will have a presence in your community. What kind of data did we need to develop sustainability people's mind at ease and allow us to make sure that what we were doing, the efforts that we were doing, are the right efforts. And I'll just give you a few bullets there that we have out there. We know that not all counties are covered by our programs, by the SSPs, nor are all the same types of SSPs. Do we have one of bricks and sticks? Do we have mobile units? Are they commingled or combined with traditional services? Are they routinized, if you will, into care? And that was one of the things that we were trying to collect data on. We wanted to know what was the population we were serving. What does that demographic look like? Are you providing information and referral, which is required? And were you providing that to educational materials? It's important for us to be able to help have a good education fund out there as well. And then the basics, how many supplies did you distribute? Were you providing naloxone? And what did that look like in the community? And what were you doing around infectious disease testing, treatment, and prevention? Those data points really became important in trying to tell the whole story of what the Syringe Services programs do for our community. Along the way, we really wanted to point you back to our website at North Carolina Safer Syringe Initiative. There's the link in the PowerPoint, and also a new public health guide to ending the epidemic is just now coming out, and it combines a lot of the great things that states and communities are doing in relation to safer syringe programs. And with that, Sharon, I want to turn it back over to you.
Thank you so much, Mr. Staley, for that excellent peek into the journey to expand SSPs across North Carolina. Your partnership with law enforcement and your look at that moral theory was really, really insightful, and we really appreciate it. Our next presenters are Mr. Andrew Gans, HIV, STD, and Hepatitis Section Manager, and Mr. Joshua Swatek, Hepatitis and Harm Reduction Program Manager at the New Mexico Department of Public Health. Mr. Gans?
Thank you so much, and we really appreciate New Mexico being invited by OASH and the regional health administrators to this exciting discussion. New Mexico is a little different than our partners in Kentucky and North Carolina in that our program has been around for 20 years, and the original basis for it was not the recently emerging increase in the opioid epidemic, but it was really based on HIV and Hep C rates. And a lot of people look at us as a model program because over the 22 years that we've operated, we've expanded a lot. Over time, we've made a lot of progress. And I would say our message is don't be intimidated. All of our programs across the country are learning and growing and expanding in spite of or with the support of the regulatory and political environment. So we didn't get where we are today right at the beginning, and we've made a lot of progress, and there's still stuff we would like to see improve in our state as well. So we don't have everything. We have a lot, but we don't have instant access to medication-assisted therapy, for example. So we also learned from our other colleagues. Just a few objectives of what we're going to talk about. We're going to talk about what we see as the best gold standard harm reduction syringe service program that's comprehensive and client-centered. If you could have everything on your wish list, what would you ask for? A little bit about our history, how we got to where we are today. Some of the strategies we use to be responsive and client-centered, as well as to deal with stigma, because even in a state where syringe services has been around a long time and is generally accepted in the community, there are still a lot of barriers and stigma and concerns that our participants still face. And finally, I wanted to share a few wins in public health from our program. So I'm sure everyone on the line has seen this many times before. A syringe service program isn't just about sterile syringes, but I like to share it occasionally just to highlight. So in addition addition to sterile syringes, safe disposal is hugely important. It's also important political or regulatory talking points when you cite the 20 years of national data showing that there are fewer discarded syringes in the community. When you get really strategic about adding community drop boxes, giving small portable sharps containers to your participants to bring back work and syringes, all that stuff is very popular. We have a lot of support from law enforcement, partly due to training and partly because what I heard about officers not wanting to get stuck when they pat somebody down. That has been really important in our state as well. Overdose prevention obviously is something we've been layering on our harm reduction service, and then we believe in navigation. So when we started, we would do referrals and try to track them and didn't get much. Navigation is where you really get somebody to these services. Harm reduction is excellent as an entry point. So I like to share some of our materials. We have a searchable statewide website and an HIV guide, and we're using it on all of our materials to point people toward finding the resources they need. HIV, STD, hepatitis, and now syringe service drop boxes across the state are searchable on our website. So we started with data from a seroprevalence study. Wow, this is 25 years ago now. And people read this differently, but very high rates of hepatitis B and C, very low rates of HIV. And at the time, we didn't realize that the low rates of HIV might be due to the types of heroin we had and the types of cooking and the mixes of population. People saw this, including policymakers, and said, holy cow, if we don't do something fast, our HIV rates are going to look like our Hep C and B rates. Luckily, that didn't happen. We also have data, we have done a lot of targeted surveillance for people under age 30, more likely to be acute or recent infections with Hep C, and seeing these big increases. So all of this is supporting the need for certain services, but this, again, predated the big jump nationwide in opioids. So our law passed in 1997, and very importantly, I know as states are working and trying to figure out what's feasible, some of you have accepted some restrictions that you didn't necessarily want. So I think about Kentucky, you've got to go through every city and county. We luckily have a statewide law, so we do listen to community feedback, but we don't need to get every city and county to buy in to open a new site. So we are authorized to compile data. There's immunity for possession of syringes going to and from harm reduction sites. It's very important to our participants. And then we have to approve every provider across the state. And we began operations a little over 20 years ago. So we are also started with some limitations that as we've learned and collected data and presented it back to our policymakers, we have made improvements. But originally, we had insane data requirements that were in state law and rule because we thought proving our program was successful was urgently important, and maybe 20 years ago with less national data it was. Eligibility is only for those age 18 and over and residents. Some educational messages were actually written into state regulations. Can you believe bleach is still appearing? But we got that written out a few years ago, thank goodness. And then exchange was written based on history rather than science as only 1-for-1 and with a limit of 200 syringes per interaction, meaning somebody traveling from a rural area for an hour couldn't necessarily do the ideal secondary exchange. So we've grown really quickly, and I will turn it over to my colleague, Josh, to share some of our stats and information.
Good afternoon, everyone. So just wanted to give you a little bit of background about what our program looks like now. So currently in the state of New Mexico, we serve around 12,000, 13,000 people every year through our syringe service program. And as you can see here on the slide, that's significant growth, especially from just a couple of years ago. Part of that was in part due to our lowering of barriers. So the long questionnaire that Andrew had mentioned, we've actually even shortened that even more. It's a very short questionnaire. So we reduced interviews and survey fatigue, so people are more willing to come in. We've also had over 45,000 syringe service sessions. So that means that of these 13,000 people that are coming into our syringe service programs, we had 45,000 interactions with them during that fiscal year of 2018. That's 45,000 times they have contacted either one of our health office service programs or our contract service programs. So oftentimes, this is the first entry into any sort of healthcare, which has been quite nice and has had some really great results. We've got service locations throughout the state and serving many different communities, including rural and even some frontier areas as well as our urban areas. As Andrew had also mentioned, we integrated overdose prevention with our syringe service programs very early on. Originally, it was only clinicians, nurses, nurse practitioners, PAs, MDs who were able to dispense naloxone. And in 2016, we actually signed legislation that allowed us to overcome that. As you can see here, the need was very high for it. We had the highest overdose rates for a decade. And then in 2016, it began dropping, and in 2017, it continued to drop. And through our harm reduction programs, that's the best way to access folks who really need to utilize our services. And the folks that are coming in for syringe services, and they're the most likely to have issues with overdose and need the messaging for overdose prevention and education. And a little bit of our history, we were the first state to enact our legislation that allowed for third-party distribution, meaning that naloxone was able to be used on someone other than who it was prescribed for. And like syringe services, we had a very, very long interview. We had a 3-hour-long training in the beginning because that was some of the concessions that we made to be able to provide a prescription medication to our community. And in 2005 and 2006, we really shortened that to a 15 to 20-minute curriculum, and we've been working to shorten that even more. So 15 to 20 minutes is good for a group now. We can do naloxone overdose prevention education and show them how to use naloxone in really about 10 minutes or less. So we've done really well with shortening that and decreasing that time barrier. In 2016, as I had mentioned, we had a law that was passed that allowed distribution of naloxone by lay individuals by standing order. And as soon as that went into effect, as soon as we had the regulations all set up, we required all of our syringe service programs to integrate naloxone distribution and overdose prevention into all of their programming. As I had mentioned earlier, our education needs to be very brief and understandable and geared towards what the clients are concerned about. We ask lots of questions. We try to see what the clients are interested in, and we get the facts about overdose prevention education. We have a lot of myths that we have to overcome, and we do a good job on that prevention side as well. We also need to make sure that those that are getting the naloxone aren't just the folks that are using, but the folks that are around them, to really get them in the community and ensure that folks that are around people that are using substances have access to naloxone. It includes parents, brothers, sisters, mothers, even law enforcement. And we also have been really successful in our data collection. So we get our information on naloxone usage when people come back in and report that they have used their naloxone. So when they come back in to get more, they will report what it was used for. As you can see here, program's grown quite significantly, almost 24,000 doses of naloxone distributed, and in state fiscal year 19, almost 3,500 successful reversals were reported by our community members to our programs.
And this is just naloxone through harm reduction, not including our other partners in state government who distribute to law enforcement, et cetera.
Yeah, this is outside the SDR, PDO grants, and all the SAMHSA grants. This is outside that. This is just through harm reduction programs directly. We've also moved towards navigation. As Kentucky, we also have very high rates of hepatitis C. So we're working towards navigating folks at the highest risk who have hepatitis C into treatment, into confirmatory testing and to treatment as part of our statewide elimination plan. We've also been able to provide vaccinations through our harm reduction programs for hepatitis A and B. This has allowed us to respond to a recent outbreak that we had quite successfully. We also have an HIV guide, which allows both our providers and people in the community to find these locations throughout the state so they can find one that works conveniently for them. We've also had additional drop boxes that we donated to the city of Albuquerque that they've recently come on board to help with safe syringe disposal. And as part of our program, several locations are also providing wound and abscess care on site where they have medical capability. And almost all of our locations are providing food and water to program participants as they come in. And some of our programs are actually going out in the community and delivering food and water to communities who don't really have access to transportation to get into town. These wraparound services have really made our syringe service program quite popular and have reduced a lot of barriers, which is why you've seen the growth that you've seen over the years.
So we'll just shift and give you a few lessons. I know we only have a couple of minutes left, but training is certainly key. We have integrated our HIV and Hep C test counselor training. We certify all our harm reductionists across the state, and we certification for harm reduction is 1 day, training for HIV Hep C counselors is 3, and then we do train the trainers. So we have a lot of partners. We work with our AIDS Education and Training Center, and so on. All of our materials are in English and Spanish. This is bragging on Think Now is for rapid HIV and Hep C testing. We present them together. Sometimes Hep C is a motivator for people who inject, and they learn about HIV, and sometimes it's the other way around. A few of our strengths include negotiated exchange. We are not a one-for-one program anymore. The best science does not say to do one-for-one. We respond to our client needs. We try to be as comprehensive as possible. We're fortunate to be a centralized state health department, so the majority of our local public health offices operated by our state health department have harm reduction services, and they're also well integrated. And when people ask, well, is it okay to have a WIC and harm reduction in the same building, we always respond with, yeah, because it might be for the same client. We try to be to the low thresholds, as Josh mentioned, reducing our survey and data collection burden. Do we really need to ask people about their sexual history when they're coming to syringe exchange the first time? And while we're confidential, we use unique ID codes for our clients so that they can be safe from have immunity from prosecution just for possessing syringes. Again, they're doing other activities at our locations that they don't have immunity for that. We work really hard to try to reduce barriers and stigma. As Kentucky said, there's a huge need in rural areas. There's a lot of overdose, and people are further from places that can help. So making sure that frontier, rural areas are served. In some places, mobile units are really cool. We've actually found that a lot of clients will prefer a fixed site location. So if you walk into a public health office, nobody knows what service you're walking in for, whereas a mobile unit might be strictly for that's the needle place. And we try to be active and client-centered. And then one thing that's extremely important that we're all working on together is continuing to reduce stigma around drug use, around the language, and, how do we talk about the health of the community? We have a lot of phrases we use in terms of harm reduction. Prisoner health is public health. People using substances are people in our communities. They're members of families. So we ask open-ended questions. We use affirming language. If they use a language for a drug or use a language to describe themselves, we're going to use similar language, but we're never going to use certain words that are not productive because clients are not going to come back if they don't feel respected, even if they need the service you're offering. And our harm reduction sites are really, truly the ideal entree point for all the services we want. Somebody might be scared or intimidated to get into a residential alcohol and drug program. But they came to harm reduction for a long time, and they met somebody they really like and trust, and that's the person they're going to ask that question. So if we're ready to listen to them and they're ready for the next step, we can help them. And one of our wins, as Josh mentioned, in a Hep A outbreak, it was among people experiencing homelessness, but a lot of them overlap with our clients. So we were able to get a lot of vaccine right into that population because these are people who are coming in weekly. And then our HIV rates remain really low. Not quite as low as they were in the Serve Health study in the 90s, but similar. We'll stop there.
Thank you so much, Mr. Gans and Mr. Swatek. You guys started this 2 decades ago, and when you've been in the movement that long, there's so much you can share with other states who can benefit from your experiences.
Thank you again.
And so, you're welcome, and thank you to all of our presenters. And now we get an opportunity to hear from our participants, and I'm so glad that we have a lot of time left for that because we really want to address your questions. If you haven't already, please type your questions into the Q&A pod, and we'll address as many as we can. If we don't get an opportunity to address your question today, we will be reviewing all of the questions and comments and analyzing the types of issues and questions that were raised from various sectors and regions of the country. And this will help us to inform our approach to expanding access to SSPs and the content of future webinars. So with that said, I'm going to turn the mic over to Ms. Karina Dan, and she will facilitate the Q&A. Are you speaking yet, Karina?
Yes. Sharon, can you hear me now?
Yes, I can. Great.
All right. Something odd happened with the microphone, but wanted to thank the speakers for sharing some excellent examples, and also to the participants. We've already got some really terrific questions in the queue. And so with that, I want to ask, I think we had a couple directed to Connie as the first presenter. Connie, the folks are asking what you've learned about best practices for optimal hours of the day, days of the week, to optimize syringe service program coverage.
Well, we found that each individual health department has to do what they have capacity to do. In financial times that we have now, it's very difficult. We have some of our larger syringe service programs in our larger health departments that not only do they are they open and incorporated into their program, but they also have mobile units. And I like the point about how these mobile units that they're using don't do just a syringe exchange. They do other things as well. So you don't get pegged as, oh, you went to that mobile unit, you must be looking for needles. But it's interesting, we have a small health department that has 5 employees in a very small county in eastern Kentucky, and they have incorporated it into their daily activity. So they have an environmentalist and a director and a front desk person and a nurse and another nursing assistant, and they've managed to find a way to incorporate that. It takes a lot of creativity, and we really haven't pushed anybody to do only what they feel like they have capacity to do. Most of them started very small, and most of them have built on that. So that kind of reflects the limited hours and that whole, that this thing has to be local. Another question someone asked was, how long are these health departments approved to operate a syringe service program? Well, they're approved until they're unapproved, if that's a word. So they're allowed to provide this service until someone votes that can't happen. And fortunately, knock on wood, that hasn't happened to any of our health departments at this time.
Thank you, Connie. We've got a good question about, that wasn't directed to any of the speakers, and possibly several may have some insight into working with angry neighbors who see needle litter around, and have you all, or has any of the speakers worked with those angry neighbors or helped syringe service programs to address the concerns of needle litter and other things that are associated generally with syringe service programs, at least in people's minds?
Thanks. This is Andrew and Josh in New Mexico. We're 21 years in, and we still have questions. And I think you have to present evidence to people based on their feelings. Some people just will never be comfortable with the idea that there are people experiencing homelessness in the same place they live, or people using substances in the same place they live. And some people actually hear the data and be impressed. So I think both the national data on how syringe services works and, that it turns syringes into commodity values. They have to come back. The other thing we do is we had one recently, and we just presented the data for the closest syringe service site to the Little League field that was getting this attention, and showed that that particular site had a collection rate over 100%, because we don't just count what comes into exchange. We also count our drop boxes. We don't count the ones per one by safety, but, we track what's coming in. And when the community members heard that actually more was coming off the street because of our program, they actually then just started talking about how do we participate in needle cleanup and solve the issue. So it depends on who you're dealing with. Some people will complain no matter what, but some people really want a factual answer, and we have the data to prove that.
Terrific. Thank you, Andrew. I guess New Mexico also got a question about the participant cards that that the Syringe Service Program there gives out. Does that seem to work fairly well for participants? And does law enforcement really embrace the participant
I think the
card?
last bit of that question cut out a little bit. I think it was about law enforcement. So, our cards work fairly well. We give them out to everyone at the exchange location. If they don't have one, we make sure that they make a new one. It's a simple laminated card. And part of that is also education of law enforcement. So we have advocates in our law enforcement community and also in a group that trains law enforcement. And we have them go out and talk to law enforcement and train them on naloxone usage. And part of their training on naloxone usage is also training on how the harm reduction program works, the benefits and the sort of regulations behind it, which is really nice. So that's reduced the amount of negative interactions that we've had, that our participants have had with police, because our law enforcement is really concerned with, as law enforcement is, with enforcing the law, and they're, don't want to spend their time on a paraphernalia charge, especially if someone's operating within the confines of the law. Another part of that program that's really important is that we have verification letters that we're able to provide to participants and judges. So if we get a message alert where one of our folks got a citation when they shouldn't have, or they might not have had their card on them, we can actually write a letter to the courts saying that this person has been engaged in the program and verify their participation in the Syringe Service Program.
Thank you. One of the questions we just got, Danny Staley, I believe, can speak to some of the techniques that have been most persuasive to engage or work with law enforcement in your state.
Yeah, thank you for the question. One of the things that we have found is first, like much of work in public health, it is a relationship, and the relationship with law enforcement, they were a partner in getting the bill passed, but they've been a partner also in doing naloxone distribution and doing response in communities as injuries have occurred. And so the first thing I would say is develop a relationship with them where they feel like they can come to you. The other is when we went and asked about, well, occasionally we would see a officer coming into the local health department with a needle stick, and so they are now on post-exposure treatment. And at that point, we started asking the law enforcement community, well, what can we do to help prevent the stick from the beginning? And, we found out pretty quickly that law enforcement doesn't always want to report these things. The officers in the field, for whatever reason, maybe it's an, I'm an officer, this is a sign of weakness if I report that I got stuck or whatever. That was the first thing that we started working on was, you got to let us know so we can get good data. And then that was the start of this whole preventing the stick issue. And disclosure, finding out this simply how, if you tell us that you've got it, then we're going to not charge you with a paraphernalia charge, which is what our law did, basically remove the barrier. So for us, it was about relationships. It was about, we worked with police to begin with on training and education on a number of public health issues, whether it's the preparedness and white powder exposure that they would get from mail when they're doing mail investigation or a threat investigation, and then also from the treatment end. So we were also having a contact with treatment, and then we started providing them data. So they became one where they valued our relationship and resource. That was how that began, and that we found that to be very helpful. And their stories, I mean, whenever they would tell us their stories about how they got stuck or what got stuck, then we would ask them, can we share this? Because I think it's a learning opportunity for other officers. And so that became an opportunity for us to be engaged with them on a different level.
Terrific. And then in Kentucky, we were very lucky in Kentucky that this whole process was pretty much led by our Office of Drug Control Policy with Van Ingram, who is the former president of the state. I want to say sheriff's office, and that's not the correct word, but he is statewide known and respected. And when Van gets up and says this is important, people do listen. So that having that right person, as someone said earlier, that is so key, to have the right person talk to the right audience.
Thank you so much, Connie. That's terrific. One of the questions we got is whether HRSA provides guidance for HRSA-funded health centers on starting a syringe service program. And I'd like to refer the participants today to webinar number 1, during which we had HRSA leadership on the line providing examples of programs that SSPs, that health centers are involved with in terms of SSP support, or even potentially housing or co-locating SSPs in a health center. There were some great examples given, and that archived webinar is available to view at www.hiv.gov/ it's under Federal Response and Syringe Services Programs. So encourage folks to go back and take a look at that. We had HRSA, CDC, and SAMHSA on that webinar, and it was terrific, almost as good as this one. So another question we got from folks was about, one of the first questions we got was around what our office is doing to put more legal syringe services programs in place. And I was thinking that the Regional Health Administrator, Sharon Hicks, may be able to speak just for briefly about that work here at the Office of the Assistant Secretary for Health.
Thanks, Corinna. And we are excited across the nation. We have 10 regional health administrators working with state and local communities to discuss what is needed around advancing access to SSPs, increasing hours, putting SSPs in places that don't currently have them, and also increasing the types of services that are provided at SSPs. So we're in the early stages of gathering information. By December, we'll have a really good idea of what the needs are in communities and what HHS resources and information might be helpful as we strategize on how to increase access. And starting in January, we'll be able to put some of that stuff to work and see if we can work with communities locally to expand access.
Terrific. Thank you, Sharon. So I heard, especially from New Mexico, but would love to hear responses from any of the speakers about what you're doing in your state to respond to the rising rates of hepatitis B. I think we've also seen outbreaks of hepatitis A. It's been huge increases in hepatitis C, and it may be easy to kind of lump those together and ask the speakers what you're doing to respond to those increases in infectious diseases vis-a-vis the syringe service programs that we're talking about today.
Well, this is Connie. I mean, we see the folks that this touches walking into our offices every week. And so I think using this opportunity to ask about testing, recommend a test. If they say no, you ask the next time, you ask the next time. When I was in private medical practice, I would ask the same question often about spousal abuse and get the same answer every time until finally someone understood I really did care and really did wanted to hear that answer. And that's when you start getting that honest answer. So I think offering those vaccinations and offering that testing, in Kentucky we are an expansion state, so we have the opportunity to get these folks not only the care, but actually meaningful care that cures now. So we're very energized with this opportunity to help cure patients. And we're looking at our Medicaid data to see how many people with a positive diagnosis actually get treated. Those numbers are not something we're proud of, and that's something we're working very strongly with our hepatitis C viral hepatitis program.
And this is Danny. I think one of the things that to follow up on the question about the infectious disease, one of the things that we began doing as we sort of set up the programs and the guidance to establishing a program was to routinize testing, because we all know that if you don't know your status and encourage immunization where immunizations are warranted, if you don't know your status, that's the problem. And so one of the things that we have to do is to break down stigma and make things like testing more routine, and even if we can figure out the ways in many areas to make it an opt-out of testing to help bring it more routinized.
Thanks so much, Connie and Danny. I also want to reassure our participants that we see syringe services programs as a critical way to reach individuals at risk for infectious diseases and to provide education when appropriate, vaccination, as well as screening and referral. And we're in the development phase of the next iterations of the National Viral Hepatitis and HIV strategic plans, and are expect that syringe service programs will be part of those national strategic plans moving forward, because there's such important prevention opportunities for infectious diseases. We got a really interesting question. I think Connie may be able to help us understand if there is any data on the impact of syringe service programs on healthcare costs.
Well, we looked at that a couple of years ago, just when our syringe service programs had gotten started, and we're re-looking at that. And what we're going to do is take our Medicaid data, look at folks with a substance use disorder diagnosis, and then look at comorbidities. What is the cost to these folks? And we're going to start looking at if the person's residence is within 30 miles of a syringe service program, are their costs different than folks who have an SUD diagnosis and are not close to a syringe service program? That data is being crunched right now, and I think that's going to be very helpful information for us to share with our legislators.
Thank you so much, Connie. I am really sorry that we are out of time for the question and answer because we have so many more great questions, but I want to turn it back over now to Sharon Hicks.
Thank you, Corinna, and thank you to our planning committee, to our presenters, and to you, our participants, for joining today. Together we can combat the nation's opioid crisis and end the HIV epidemic, and one way is to achieve these goals through expanding access to SSPs. On your screen, you will notice that 6 questions have popped up. Please take some time now to let us know your thoughts about this and future webinars. We will follow up with a recording of the webinar, a link to the presentation slides, and the contact information for your regional health administrator. Thank you for your participation, and I trust that you are leaving better informed about state and local perspectives and inspired to do what you can to increase access to SSPs in your community. Enjoy your day.